Hi there. This is Rahul Desai, regenerative radiologist and interventional and restorative sports and spine specialist. Today, we're going to be talking about regenerative medicine and photobiomodulation and combining these modalities. So this is a comprehensive review for clinicians, medical providers, trusted wellness advisors, anybody that's out to help patients get better and overcome obstacles with their physical bodies. And what we want to do is enhance outcomes with medicine injections and photobiomodulation. So this is a little bit about me. I went to medical school, medical doctor, and did a radiology residency, did a fellowship in interventional sports and spine medicine, and then have done this for my career for about 15 years, really focused on regenerative medicine, autologous cells, helping patients heal and get better, and all of the adjunctive things, around that. We created RestorePDX, which is a state-of-the-art facility in Lake Oswego, Oregon, uh, dedicated to interventional orthopedic medicine and education. I am currently not practicing, but Dr. Capelli is. He is a fellowship trained sports medicine physician, comes from an emergency medicine background, and is helping out our patients in the community, doing a fantastic job, and is also well versed in, has about 10 years of experience in regenerative medicine and injection therapies for both joints and spine. So welcome him to the community. Thank you for my family for giving me the time in the evening to be able to do this and talk about my passion in medicine. We love nature, hiking, travel, and the family's most important thing to me. This is us traveling around the world and just having an amazing time, and really just so grateful to have them in my life. Want to talk a little bit about my background and why it's relevant is, it's a very standard medical education that provided an amazing foundation. I did a Bachelor of Science. Go Buckeyes, had to put that in there for our national champs. Went to medical school, radiology residency, did an internship in internal medicine, and then a spine and joint fellowship with imaging and interventional procedures at Washington St. Louis. That gave me a fantastic foundation of training, and I was really good at figuring out what was going on with someone and putting a needle pretty much anywhere that needed to be placed. Before I found regenerative medicine, we kind of felt like we were kicking the can down the road, and patients almost always came back. I referred a lot of patients to surgery, uh, and a lot of them needed it, and a lot of them didn't. A lot of pain patients came back after surgery with more pain and dysfunction, and it was kind of this really frustrating cycle. And those were the standards of care that we had at that time. But 2008 and 9, I was introduced to regenerative medicine, and it took a bit of a leap of faith. There weren't a lot of compelling studies. There was a few compelling studies, not a lot of information out there. But one thing that we looked at in the literature was that it was very safe. We had a patient, our sentinel patient was a 25-year-old male that had had an injury while skiing and had a partial tear of his rotator cuff. Had significant pain for a couple of years, had a couple of cortisone injections. The cuff was partially torn or degenerating, but not bad enough to need a surgery. And the conventional injections, conventional physical therapy, everything, it wasn't helping him. So he was really suffering. And we talked about, regenerative medicine as a potential option. He was very interested in it. We did, safety profile, looked at all of the data, talked to docs that were actually doing it around the country and world. And we decided to do a simple platelet-rich plasma injection. This was the supraspinatus tendon, and as a radiologist, we had really good, diagnostic skills, and we saw this tendon was degenerating. There was calcium deposited in it, and everything else looked pretty good with just a really, worn out rope. Right, that tendon is like a rope, a healthy tendon, type 1 collagen fibers. There was calcium in it. There was a hole in it, and it just wasn't healing. It was stuck, and all that's bright here is a bursitis, subdeltoid bursitis, and it's really painful. And so this is that degenerative pathology that we see. It was acute, it was chronic on acute, right? You had an injury, and then it kind of it didn't heal, and this rope started fraying and coming apart. It wasn't completely torn, right? But it was breaking down, and you can see these histologic pictures of what was actually happening to that tissue. And the question is, can we take this and reverse it? through a biologic, by activating the body and seeing if it can heal. We want to go backwards in time from a hole and to fill in and see if we can get this nice rope to refill. And lo and behold, we did the therapy, and it's this is a circle around this diseased tendon. We precisely, with ultrasound guidance, put medicine into that tissue. 6 to 8 weeks later, he came back feeling amazing, and we just needed to see what was happening. So we put him back on the MRI scanner, and lo and behold, it was normal. And I had never seen anything like it. Was pretty shocked. Patient was doing fantastic. Sent it to my professors at WashU and other folks that I've known, and people are just kind of shrugging their shoulders. And it took about 15, 20 patients to see this over and over again to really believe it. This was another example, even more profound, really severe Achilles tendinopathy and partial tear. All of this, it should be nice, dark, and thin. This Achilles tendon, we're looking at the foot from the side. This is an MRI, and there's a big gap. This white is a big tear. One, the rope is really frayed and uh, not healthy looking. It's thickened and angry, and there's a gap. And you can see this gap right here. So we filled that with PRP, with ultrasound guidance. So here's the ultrasound. We didn't have this for that shoulder, but we didn't have the pictures here for that shoulder, but this is what we did. We had identified the hole, and we placed this needle. This is a tiny 25 gauge needle into that, and we filled that defect with the platelets that we had obtained. And over the course, and we followed it. So over the course of 4 months, we looked closely at this because this was now, I was curious, like what's actually happening. So we kept on scanning, and we see that here's a hole, right? And it's starting to fill in. It's kind of a gamush phase. Something's happening here. There's like little connections. It's starting to fill in more. There's more tissue coming in. This is looking down the barrel. So that's the healthy tendon. This is the tear. The dark is the healthy tendon. The bright is the tear. And it's just starting to go away and fill in. And within 4 months, it had filled in. Now, this is not perfect looking, but patient was pain-free. If we scan it, a year later, it's going to be more organized, thinner, and it's pretty amazing to see those changes. And we have another patient, very similar but worse, a really large tear. This was years later. This is 2021, and there was a big hole in it. We filled that up, and this time we used bone marrow, fat, and platelets. We had kind of refined our skill sets, and this was the follow-up a year later, completely normal looking, and I can attest to an amazing feeling as far as the patient's pain levels and functionality, because that was me. It was amazing. I used, this regenerative medicine, photobiomodulation, which is the red light, near infrared light, extensively used shockwave therapy. And so some of the other things, and why I showed you these examples is really to make a point of how powerful regenerative medicine can be. And these are black and white. This is another example we talk about. Those are soft tissues and tendons. This is cartilage. So there's a big hole in the patella. This is an MRI from 2018, 35-year-old male, and there's a big cartilage lesion. This is arthritis, right? This is a traumatic chondral injury. There's a big effusion and a big hole in the surface of the patellar cartilage. That is not supposed to heal. This is 4 years later after a cell therapy injection, and the patient came in for the opposite knee, and we scanned them, and that had actually filled in with new cartilage. So that didn't need an Oates procedure or microfracture or anything. That was simply injection of stem cells, their own cells, bone marrow, fat, concentrate, and platelets into the joint. And here you can see a sagittal view of this, right? So this is kind of proof of concept, and we're seeing these cases happen, and it's not isolated. Here's another case where there's a full thickness defect. There's actually a little bit of swelling, so they call it subchondral edema in the bone, and delamination of the cartilage. This patient we injected with stem cells, their own cells, into the bone marrow, and we actually injected in the bone. So the dark here, you see these little lines, that's contrast in the bone. Here's another example of contrast in the bone. It's going to that subchondral plate. The cartilage we can't see the cartilage here. This is an X-ray or live X-ray fluoroscopy, and we're documenting where that's going. This was 6 months or a year later. We wanted to see what that was looking like. Patient was doing tremendously well, and when we look, there's a new layer of cartilage. It's not full thickness, so it's not all the way back to where we would like to see it, but it filled in. And also that underlying bone looks much healthier. It's not swollen or inflamed. And this is pretty incredible. So it's a full thickness defect. The bone here is kind of like the soil. It's weak. It's starting to break down, and this is going to lead to the progressive, arthritis and worsening. And here you see it's filled in. right? And the bone is healthier underneath. That soil is aerated, it's healthy, it's going to support the grass on top. So pretty fascinating. And so whatever we can do to, to help these cases with adjunctive therapies is what we're looking for. So sleep, nutrition, shockwave therapy, photobiomodulation, or red light therapy, all these things. Here's another example of a knee that's super swollen. All of this bright is bone marrow edema, full thickness cartilage defect. Here, the meniscus is bright, it's kind of wearing down. So just a super angry knee. And this was just after an injection of cells into the joint. I don't even this patient didn't even have it into the bone, and they did tremendously well. So all of that bone marrow edema, the swelling has gone away, and who knows in time we may see new cartilage. We'll see. The meniscal tissue also looked healthier. It was really wearing down. That improved in its appearance. So some of these changes are pretty amazing. And the PRP was kind of our introduction, and then it was kind of the gateway drug to all of these other cells. When we talk about the kind of the panacea of regenerative medicine, it includes platelet-rich plasma, growth factors, our own cells from bone marrow fat, PRP. That's what's you can use most of those legally in the United States, and then there are also placental tissues, exosomes, all kinds of other um, tissues that are being developed to biologically affect systems and help with healing. And so it's fascinating. Some of it's the science, some of it's the regulatory issues as far as getting access to it. When we talk about growth factors like PRP or there's growth factors in there that are stimulating the growth of tissues and healing. I liken that to if we're trying to get crop to grow, we need fertilizer. Right? We have this garden, it's not giving enough crop. We want PRP or growth factors, something that's going to help stimulate healing. If it's a barren patch of dirt or a more severe injury, that's when we want cell therapy or something a little bit stronger. Our cell therapy comes from fat. We go to bone marrow. We oftentimes enrich that with PRP and then we inject it. This is obviously in Portland, we need them sometimes. We need umbrellas. We don't use them, but we could use them. But the umbrella of regenerative medicine, and here we have A2M or alpha 2 macroglobulin, IRAP, which is interleukin 1 receptor antagonist protein. These are things that can help reduce inflammation. They're almost like a natural steroid. May not have the most powerful healing abilities. As we move to the right on this umbrella, PRP, growth factors, extracellular matrix, even prolotherapy, stimulates healing a little bit more robustly, and then bone marrow aspirate concentrate, lipoaspirate concentrate of the fat grafts and other stem cells from different sources are probably the most powerful at this point. This is a picture of the different injections. These are all from the patients. We have platelet-rich plasma. We have a bone marrow aspirate concentrate. We have lipoaspirate concentrate. We have platelet-poor plasma. So a lot of tissue was taken from the patient that was created in a sterile lab. We don't have to add anything to it. It's just removing the stuff we don't want and concentrating the best biologic factors. These are then injected into the patient under X-ray guidance. And that can be done in clinical settings. It can be done in a surgery center or in an office-based lab. And you can see that sometimes there's mixtures and all of these different structures are precisely injected individually. This is an X-ray example of a doc taking bone marrow aspirate concentrate, so a needle going into the bone. So everything's image guided, right? And you take that kind of trajectory and everything is done very safely. And then you're able to aspirate cells from that. Here's a CT example of a specific device and showing that device going into the bone marrow. And then also ultrasound guidance is used for liposuction or lipoaspiration. This is a metal cannula that's placed into the tissue. The tumescence or fluid is placed into that fat tissue to break that down. Everything is done under ultrasound guidance, so it's extremely safe. So you can see the different fat layers. So here's the muscle layer, here's the fat layer, that's the cannula, and you can see kind of these cloudy areas. That's where the fluid is actually going into, and then you have to let that sit. And actually, the medical term is percolate. So here is untreated fat. It's kind of dark. This is fat too, superficial layer. There's a fascial layer here. That's a deeper layer. Here's a cannula going into the fat. We put the tumescence or the fluid in there and we let it sit for a while. And this is what it looks like afterwards. You can see it's darker here and it's brighter. It looks almost like fluffy. And that's what we aspirate out. So this is infiltrated echogenic fat. So everything is done with image guidance. Super cool, extremely safe. And here's an example of this process. When that is removed, then that is processed sterilely in the lab. We get rid of that tumescent fluid, we get rid of the oils, and we really concentrate some of the collagens and the extracellular matrix and the cells that live around the blood vessels in the fat. And this is what it looks like afterwards. So here is the fat, looks really pretty, and it's almost like a biogel or scaffold. You can see the thickness and viscosity of that. And so when we're injecting specific areas, we wouldn't inject it obviously into blood vessels or in an IV or in something that's unsafe, but into soft tissues, into a ligament, into a tendon, into a meniscus, into a disc. This is a really great bioscaffold, and it's all the patient. There's nothing added. Really, it's built for them, by them. You can combine that with bone marrow, aspirate concentrate, which again are all their cells, or even platelet-rich plasma to stimulate that, get the fertilizer and the seeds. So this is a really compelling and fascinating use case for this tissue, and it can heal. And we see this over and over again. This is a really bad common extensor, so golfer's elbow, a large tear in the tendon attached at the elbow. And there's that bright is a big hole in it, and here it's filled in on the post. This is the hole that was there, and there was also an effusion in the joint because the joint was inflamed, it was unstable, and afterwards you can see that is now filled in, and there's no effusion, so it's a much more stable joint. Rotator cuff, there was a near full thickness tear, and you can see the progression under ultrasound of the healing. So this dark is a hole. Here's the bone, the tendon, and then there's a gap. That gap is filling in. It looks a little bit disorganized, and now this gap is filled in and it's more organized. It's not perfect. There's still a little bit, so maybe we need to come back in and put more here, but over time, that may heal. And here's an example in the same patient with MRI. There's the gap. I call this kind of the gamush phase. That was a few weeks out. There's like a bioscaffold, but it's not very organized. And here now we have this really nice organized tissue that's connecting that tendon to the bone. So really fascinating. We are seeing incredible. If you had asked me, say 5 years ago, about can you heal a complete ACL rupture, I probably said no, not with regenerative medicine. Probably need surgery. Well, I retract those words. I think that it's happening, and we're seeing it over and over again. This is a complete ACL rupture. Here, the ligament is kind of hanging in the breeze. It's completely torn. There's kissing contusions from where the bones translated and they impacted as they went back. This patient was evaluated by orthopedic surgery. Surgery was recommended. They chose to try cell therapy. So with very specific parameters, you saw the cells that were using bone marrow fat and platelets. We injected the course of the ruptured, torn ACL. And within a few weeks, we saw that there was connectivity of that ligament, right? And then within a few months, it looked normal. So it went from this torn and sometimes completely ruptured, but opposed. I mean, if there's a large gap, you probably need a surgeon to put that back together. If it's torn, but what we're seeing with like the ACL, it's torn, but it's somewhat closely opposed, that the body has some intelligence to be able to heal that. Here was an example of a professional horse rider. This was their horse, and they ended up on the wrong side of this hoof, and they got kicked. They spooked the horse. They looked down at their knee. The knee had been kicked. The patella was dislocated to the side. They had completely ruptured their MCL. They tore their ACL, and then they dislocated their patella. So the medial patellofemoral ligaments were all torn. We talked to them. There was going to be 3 surgeries, 18 months of rehabilitation. And we talked to them about doing regenerative medicine and treating all of those areas at the same time, allowing it to heal, prayer, red light therapy, and time, and see if those tissues went back together, realizing that it may not work and they still may need the surgery. But we did that. And this was, they were from out of town, and they had access in their hometown to MRIs. And so they were getting them quite frequently just to know what was going on. This was a few weeks later, and we started to see that there was connectivity of that ACL. So it wasn't perfect. They were still having some pain, discomfort. They were starting physical therapy. And that ligament, which had been completely ruptured, was actually started. It was connected, but it was lax, right? It wasn't nice and taut. And so we see this kind of laxity and a little bit of signal abnormality. It's a little bright, a little soft in there. And you can see here, this is another view of that ACL, that ligament. And we're starting to see it's connecting. The medial patellofemoral ligaments, this was another MRI subsequent. We see them starting to connect again. The ACL is looking thicker, and it's actually looking a little bit more taut. Here's a really nice view of that. So it's really tight now, but not perfect. And then they had another scan, This is 7 months later, and you can see how it's super tight, very taut. They're doing really well, zero pain, writing again, and the MRI was read as normal. So they were able to leave with Band-Aids. It definitely wasn't, we have to extract all that tissue. We have to put it back in. It's painful for a few weeks. So it's not magic, but it's something that is really changing the game. The MCL, which can heal over time, even a grade 3, did really, really well over the course of those 7 months. And here's the progression. It was nice that they were able to go and get these MRIs, but a complete ACL rupture at 7 weeks, at 11 weeks, and then at 7 months. That's the progression of healing. And they used red light therapy and photobiomodulation every day. Combination therapy. We talked about what it looks like under MRI. This is an example of ultrasound. So this is a really compelling case where there's holes. This looks like Swiss cheese. This is the common extensor tendon at the elbow. So this is an ultrasound of that. This is the humerus. This is the radial head. That's the joint line. This is the tendon that it's attaching to. And this is down by the hand. This is up at towards the shoulder. And all of these black areas are holes. Those are like if you're looking at my fingers, the fibers are my fingers and the holes are the gaps between them. And so that's a severely painful and partially torn tendon. If we look at the opposite side, this is what it should look like. So it's smaller and it's contiguous. You can see all those little white lines. That's the normal type 1 collagen. Here you see all of these holes. That's the symptomatic ouchie side. This is a needle placing fat, bone marrow, and this might have been fat and PRP mixture into the tissue, into the holes. And you can fenestrate and kind of make some passes through that tissue and then place this fat into all of the holes. So that's that scaffold, but it's full of powerful growth and healing factors and cells. 3 months post-visit, they had 0 out of 10 pain at the visit, worse, about 3 out of 10 with repetitive motions, about an 80% improvement, overall doing great, physical therapy going really well. When we look at it, all those dark holes now have this bright stuff in it. If a doc doesn't know or a radiologist doesn't know what was done, they may assume that this is calcification or maybe this is bad stuff. This is not good. What we realize, though, is that this is the remnants of that fat. It's the scaffold, right, that's still staying there. And it looks less, here it's kind of this big glob. Here it's a little bit less conspicuous. It's filling in a more form into these areas that were damaged, but it's there, right? It's still present, which is fascinating at 3 months. So that bioscaffold has actually stayed and it's slowly, providing that structure to heal. 4.5 months, continued improvement, 0 out of 10 daily pain, very minimal occasional pain with repetitive movements. And you can still see that there's still a little bit left and it's becoming less and less obvious or conspicuous. At 9 months, this tendon looks normal again, right? So you can see this really nice, all the fat has resorbed. Maybe you can pick some out there, but overall the fibers look well aligned. It looks tight. That rope is rebuilt. Super cool and awesome. So here you can see all of these holes. 9 months later, this is filled in. And, so we can see this over and over with all types of different tissues. Here's a meniscus that was torn that had a meniscal cyst. Same thing, we went in with ultrasound guidance. You can see the meniscus, placed the reparative material into all these holes and gaps, and it broke up that cyst. Here, months later, that tissue is coapted. Even though you see a little bit of increased signal intensity, there's no tear, and then the cyst is resorbed, which was fascinating. And this is an ultrasound of when replacing the material. That's the meniscus. We're kind of looking from the side. That's the femur, the tibia, the MCL, and here's the meniscus, this triangle. And you can see how clearly, we put in the needle, you can put it right into here and then deposit that material into the tear. Here's a meniscal root tear, which these are really, really challenging to heal and actually connected, right? Barely, but patient's doing really well. And from this really degenerative, almost complete tear, they had a tremendous improvement in functionality. This was a 70-year-old that went back to dancing and did really well. Did not have to have a major surgery, and they were looking at probably a knee replacement. We're also seeing these sort of things in the spine with disc herniations. This was my first patient, patient 1 or 0. This was a huge disc herniation, and this was the first epidural PRP injection that we did years ago. Kind of scary. And you can see that there's a tremendous reduction in the disc herniation just after a week, and this is a few weeks later. So we did this patient, almost immediate pain relief. They had failed multiple cortisone injections, and instead of putting cortisone in the same place, in the epidural space, platelet-rich plasma was placed in there. And that was our first, kind of exercise in regenerative spine. I'm kind of an orthopedic mess. I have some form of Ehlers-Danlos, so you can see my thumb bends like this. I can touch my thumb to my wrist. My elbow hyperextends. So I'm very hyper flexible, but that's not awesome for my ligaments and tendons and joints. And they oftentimes break down. So this is actually my back. I've had a intradiscal injection with regenerative medicine. You can see that disc placed at a disc tear, super painful. And this was game changing for me. So instead of having to have, surgery or discectomy or God forbid, progressive disease, I was helped, and it really changed the trajectory of my life. And that's why I'm so passionate about this. So we're seeing these huge herniations like this one, large extrusion herniation, injecting regenerative material in a very similar fashion to traditional injections, because you're just supplanting corticosteroids with this reparative material. And we're seeing, here's a huge herniation. A few weeks later, it's completely gone, and patient's pain is relieved. And you may argue that this might go away on its own. That is absolutely true. But when patients are coming to us for this type of therapy, this is not I hurt myself and I want to get it fixed right away. Most of the time, at least where we've been, in the future, I think that'll change. But where we've been is this is a therapy of last resort. It's not covered by insurance. There's a lot of disbelief and misinformation around it, and so that's challenging. But I think that once this gets more exposed, people understand what it's doing and how it's helping, this will become a standard of care. And here you can see kind of a top-down view of the spine. These are all slices through the spine, and you can see here, there's the disc. This is the facet joints. This is the nerves. And here you can see on this slice a really large disc herniation compressing the nerve. Patient has back pain and sciatica. And this is the post-treatment where you have the disc, the herniation is completely resolved. And that's with just a simple injection. There's still a little bit of bulging here. It's not perfect, but patient is doing tremendously well. And we've changed the trajectory of that disease process. And then many times we're seeing that it doesn't come back. And we can treat thoracic discs, which are harder to do surgery on. They're harder to access, but they've done really, really well. Here's a herniation. And now that's just a minimal bulge. Patient was doing very, very well. Really didn't have a lot of options. So what does this have to do with red light therapy?